numerous teaching awards in the BC and in Canada, and also been on the writing committees for the CCS standing guidelines. And I just started to do that, so I can see. I thought I'd just introduce Graham to start. So Graham is going to give us a talk on short and long-term management of SCAD.
Thank you, Jackie. Okay, so I get the first talk after the muffins. And so 50 minutes, the coffee will hold you for a short term, and then the muffins will kick in. So whoever's following me, I feel bad. So I have a couple of conflicts of interest that you can feel free to look at and take my talk in that context, although there really is nothing that really should influence this talk. So people have always told me that it's always important to start with a case. So we're going to start with a case. The case is really real, I kind of made her up. But this is a typical case of someone that you might see with spontaneous coronary dissection. So a mythical 44-year-old athletic female, she fits the profile. No cardiac history, presents with a typical episode of chest pain, slight tachycardia, but otherwise unremarkable. Initial troponin, old fourth generation troponin was elevated. ECG really doesn't show much, but because mythical patient presents to Vancouver General Hospital where we suspect SCAD and everything, she gets admitted and she gets sent to the cath lab. And when she gets sent to the cath lab, she has typical type 2 SCAD, as you can see over here. And let's see, where's the other one? There you go. And so the decision, appropriately so, because we've been very well trained by Dr. Saw, is to leave her alone. So she has conservative therapy, and the question is, what do we do with her? So before we go and have this long discussion, and I know that you guys have already been educated by a great deal had a great deal of information for people who know a lot about the subject. Before I think we dive into SCAD specific stuff, let's view from 10,000 feet. Review exactly what we want to do with any patient who presents with acute coronary syndrome caused by malperfusion of some culprit vessel, leading to decreased blood flow to myocardium, causing ischemia. So, first of all, what we want to do is we want to reperfuse the culprit vessel, and following reperfusion of the culprit vessel, there's a couple of important things that we want to be able to accomplish. Number one, we want to prevent the vessel from closing up again. We want to prevent mechanical complications of the index event. We want to prevent or reduce the likelihood of a repeat acute coronary syndrome causing acute infarction. We don't want people to die. All right, so how do we achieve these goals? Well, in patients who have traditional atherothrombotic causes for acute coronary syndrome, we give them drugs, we give them more drugs, we give them drugs and tell them to exercise, and we put gizmos into people. Okay, so that is essentially, this is a medical residency for CCU. So then the question is, if you accept this sort of reality, how's the difference of ACS from SCAD differ from ACS due to atherothrombosis? Well, it all speaks to the fact that they're caused by different things, and you now know that this is the mechanism for SCAD. It is a tearing of the artery, so what I tell the residents is, your vessel is like an onion cut in cross-section, and you have little onion rings. And what happens is you have a new little layer between two onion rings that basically compromise the true lumen, and that's how you got reduced blood flow, as opposed to atherosclerosis, in which the lumen is occluded because you had an intraluminal pimple of cholesterol that blew up, like the pimple on the teenager's face just before prom. And that's the reason, and that's the mechanism for that occlusion. So clearly the difference in mechanism causing acute occlusion should result in acute treatment differences. And so the goals, in addition to what we talked about for all patients with acute coronary syndrome, we're going to add three other things to patients with SCAD because they are different. Number one, absolutely need to control the discomfort, especially if you have, quote, done nothing, right? Conservative therapy is code for we didn't do anything really to you. We want to minimize the complications of the acute ischemic event. We're going to talk about the differences between atherosclerotic ACS and SCAD ACS in terms of the complication rates. And thirdly, we want to take this opportunity to educate the patient who's probably never expected to have a heart attack, wouldn't believe the fact they had a heart attack, probably is in a great deal of denial, and appropriately so, because there's going to be some important lifestyle changes that we're going to go and impart upon this individual. individual, and they may or may not be in relief of that. So, in terms of the short-term clinical outcomes, I'm sure that you guys have seen this in some way or form of the other, but the bottom line for this, this fairly complex table is that the short-term mortality is happily not so bad. But the problem that you get is sort of more on that right-hand side, where the issues become when you get recurrent events caused by recurrent SCAD. So the implications of the data we have so far is, because the short-term mortality, including complications in hospital, are low, we could perhaps have a little bit of a sigh of relief if we don't have to do an acute intervention on the culprit vessel. However, the real problem comes in terms of long-term. Although the mortality of a SCAD event is relatively low, again, the literature that's available to us would suggest anywhere from about a 1 to 4% mortality, probably closer to the 1% range. It's the morbidity that we really need to go and worry about. And the morbidity is driven by the tendency for people to have SCAD events again. So the question is, what do we have in terms to guide therapy? Do we have randomized data? Do we have guidelines? No. We have the next best thing, though. We have Dr. Saw. And essentially, the totality or near totality of the data that I'm going to talk about is driven by Dr. Saw. So my sort of comfort is the fact that I just phone Jackie and tell her what we're supposed to do with this individual. And so her data has actually driven a lot of the field, not only in terms of short-term management, but also the long-term management, because of our better understanding of the pathophysiology of the long-term consequences of the index event. So let's get back to our original rubric here about the goals of what we want to prevent following an index ACS of any kind, right? We want to prevent occlusion. How do we do that? Drugs, gizmos. Let's now lay on what is different when you have an ACS due to a SCAD. Sorry, I kind of screwed up the animations here, but preventing re-occlusion, very controversial as to the types of antiplatelet agents that you use. We know that anticoagulants that we use, the intravenous heparins and the other oral anticoagulants, either have no role, or they're dangerous, or we just don't know. Preventing mechanical complications for which we use ACE inhibition to prevent negative remodeling, beta blockers to prevent mechanical complications. We essentially ape what the ACS guidelines for atherosclerosis and assume that they work the same mechanism, because LV dysfunction is LV dysfunction is LV dysfunction. In terms of recurrent infarction, because this is not an atherosclerotically mediated mechanism, a statin or lipid-lowering therapy has no role, and therefore the amount and types of medications that we try to prevent acute events is somewhat controversial, but again, Jackie has some insightful data about some of the medications that have been shown to be helpful. Zero data on whether or not defibrillators are beneficial if you have someone who would meet the criteria, but again, what we would tend to do is to sort of port over the data from non-SCAD ACS that has VFET. Okay, the good news, however, is we talked about the fact that the short-term mortality is low. We talked about the fact that the long-term mortality is generally also low, and that countless speakers before you have reinforced upon you the fact that SCAD tends to get better by itself, right? And the good news is that the SCAD gets better by itself. The complications associated with impaired blood flow from the SCAD should also get better by itself, or at least not recur. Now, the long-term natural history was nicely done with a recent publication out of Jackie's lab, published earlier on this spring, where they took about 420 patients in a registry, and a number of them had repeat angiograms, and they found that the vast majority, I think what 95%, had spontaneously healed at a median follow-up time of around, I think, 4 years or so. But I think the baseline TIMI3 flow here, I can't remember exactly when all those angiograms are done. I know they weren't done in 4 years. I think they might have been in 80 days, the median follow-up angiogram. So the good news is the vast majority of your patients will angiographically heal. So that takes care of the whole issue of spontaneous resolution of blood flow to the myocardium at the index event. The Canadian SCAD study, which was presented last year at the European Society of Cardiology, adds a little bit more information to that, and it gives a sense of what are the clinical complications of a patient with SCAD, and also the event rates up to around 30 days, which is about as good as we get in terms of cohort data. As you can see here, this sort of reinforces the message that people have talked to you about before. Very low rate of death, relatively higher rate of unplanned MI, and this is again speaks to the tendency for SCAD events to occur again, and this speaks to some degree of a need for unplanned revascularization. So, if you do have a recurrent event or the index event does hit you quite hard, we know that a certain percent of people will have impaired ventricular function, left ventricular dysfunction, and the literature has defined that equally as an EF of less than 50 or an EF sometimes of less than 35. Happily, the left ventricular dysfunction overall in the vast majority of SCAD patients in cohort studies has been relatively low, around 6 to 8%. And this is a study that was just published as well. And this was a very small cohort study from Mass General Hospital. And they had a follow-up of SCAD patients, and they found that about 40% of them, when their index events had a poor ejection fraction, but almost 2/3 of them recovered their LV function. And the implications of this is that there are mechanisms that are likely distinct to SCAD, that are different from other known mechanisms of LV dysfunction, from remodeling, which would get better with an ACE inhibitor or beta blocker. We just need to go and do some more research to try to understand that. But this is actually fairly good prognostic information for our patients. In terms of the therapies now that we utilize to try to prevent these events from happening, Jackie had very nicely shown that some of the predictors of whether or not you will reinfarct include hypertension. And one of the things that will prevent reinfarction and recurrent events is urine beta blocker, which has led to the current pattern of practice that we do here at Vancouver General Hospital when these patients are followed after their index event. Because we know that the vast majority, or at least a significant proportion of patients following an index event, had it because of an acute physiological stressor, whether it's psychological or mental, we believe that the intervention of cardiac rehabilitation, which has baked into its psychological support, is critical to the post-SCAD patient. And Annie Chu, who was a trainee at the time, is now one of her colleagues, published a really nice paper in the Canadian Journal of Cardiology showing the benefit of cardiac rehabilitation, which is a multimodality and multidisciplinary approach to lifestyle modifications following an acute event, can be helpful. Now, the practical implications that were suggested in this paper is that you really want to decrease the DP to DT from isometrics, and therefore you want to discourage really heavy weightlifting, both in men and women. You want to target a somewhat lower heart rate and target blood pressure with exercise, so you just want to dial things back a few notches. And so this is an important consideration because a lot of your patients, as you've heard before, tend to be fairly high-level athletes, or at least people who really like to be fit, and that's why it's such a clang to them. And now you have to tell this very high-level athlete who's a runner, who's a weightlifter, who's a cyclist, you can't do heel repeats anymore, you can't go do deadlifts anymore. And that's a challenge for them to accept that, but that again speaks to the education. And what we do here in Vancouver General, the bulk of the data in terms of preventative medicines lies in two drugs, aspirin and some form of a beta blocker long term. Everything else, there's very little of no data, so we don't tend to use those at all. So, in conclusions, and I think I'm on time, and I've color-coded these so that they're easily read. We have to understand that an ACS caused by SCAD is a very different beast than an ACS caused by atherosclerosis, and therefore it goes to follow that the short and long-term management should be different. The good news is that ACS from SCAD tends to get better both angiographically as well as clinically, and that the long-term impact on left ventricular dysfunction is minimal, and if you do get left ventricular dysfunction, a great deal of them get better by themselves. We know that the goal of inpatient management followed by outpatient management is to minimize the likelihood of a recurrent SCAD event, and that can be achieved both with judicious use of aspirin and beta blockers, but more importantly, education, avoidance of physiological and psychological stressors, and cardiac rehabilitation is a fantastic entry point to get those goals done. Future research obviously is required to understand the impact of these adjunctive medications and interventions, and a lot more research is needed to go and understand the natural history beyond 30 days to beyond 1 or 2 years. And as well, I don't think we know as much about the cellular mechanisms that underpin why people undergo SCAD, which will then give us a bit more insight as to what types of medications potentially that people should be on but aren't on now because you just don't understand that. But with that in mind, that's pretty much all I need to say. And yeah,